Next in, I call in Dr. Diana Mathew. Before that, we require audience poll for giving marks for these students, for these teachers. So it will be 1, 2, 3, and 4. So after the next talk, we will have the marks for all these people, for Dr. Aishwarya. But after that, after each talk, we will have that 1 minute for the poll. So let's move to the next talk. Dr. Diana will be speaking to us on oculomotor nerve and its pathologies.
Hello. Good morning, dear students. Yesterday, I got a call from neuromedicine Mathew. There was this 70-year-old lady admitted with history of sudden onset double vision, followed by drooping of her right eye upper lid. On examination, there was complete ptosis of her right eye with the eye deviated out and pupil dilated. So, what is your clinical diagnosis? Yeah, this is a case of right-sided third cranial nerve palsy. So today, we will deal with the anatomy of the oculomotor nerve and its relevant pathology. Here is my lesson plan, vertical integration with anatomy. Hope you all are thorough with the anatomy, innervations and actions of all the extraocular muscles. In the eye, the third cranial nerve supplies all the extraocular muscles except superior oblique and lateral rectus muscle. Now tell me, which cranial nerve supplies the superior oblique muscle? Yeah, it's the fourth cranial nerve. The third cranial nerve also supplies sphincter pupillae and the ciliary muscle. The oculomotor nerve emerges from the nuclear complex situated in the midbrain, then it passes forward as the fascicular part, reaches the interpedunclar fossa as basilar part, then it reaches the cavernous sinus from where it reaches the orbit. Now we come to some details about oculomotor nuclear complex. Oculomotor nuclear complex is situated in the midbrain at the level of superior colliculus. It is related above to the floor of the third ventricle and the fourth nerve nucleus below. The main motor nucleus is composed of 3 subnuclei. They are lateral subnucleus, medial nucleus, and central nucleus. The lateral subnucleus supplies ipsilateral inferior rectus muscle. It again supplies ipsilateral inferior oblique muscle. It also supplies ipsilateral medial rectus muscle. The medial nucleus supplies contralateral superior rectus muscle. The central nucleus supplies bilateral levator palpebral superioris muscle. The accessory parasympathetic Edinger-Westphal nucleus supplies the pupillary muscle. The fascicular part then passes through the red nucleus. The basilar part starts as a series of rootlets before it coalescing to form the main trunk, which then passes between posterior cerebral and superior cerebellar artery. See here, the nerve runs parallel to the posterior communicating artery, a frequent site of aneurysm formation. That is an emergency. Within the cavernous sinus, the nerve travels along the lateral wall above the trochlear nerve. Inside the orbit, anteriorly, inside the cavernous sinus, nerve divides into superior and inferior divisions. The superior division supplies superior rectus muscle and LPS muscle. Please note, the inferior division supplies inferior rectus muscle, inferior oblique muscle, and medial rectus muscle. The branch to the inferior oblique also gives parasympathetic fibers to the ciliary ganglion. You can see the ciliary ganglion. The postganglionic fibers then pass through short ciliary nerves and it supplies sphincter pupillae and the ciliary muscle. The main trunk receives its blood supply from vasa nervorum, whereas the superficial pupillomotor fibers receives its blood supply from bile vessels. Now we will have a quick look into the pathologies at different levels. At nuclear level, vascular or mass lesions are common. These are all different clinical presentations. At fascicular level, the lesion will result in various syndromes like Benedict, Weber, Nagel, and Claudy syndrome. Please write down, as a homework, please write down the clinical presentations of each of these. Since the nerve is unaccompanied by any other cranial nerve in the basilar part, the lesions like aneurysms or traumatic EDH or STH will result in isolated third cranial nerve palsy. Within the cavernous sinus, the lesion will result in third cranial nerve palsy associated with 4th, 5th and 6th cranial nerve involvement. Regarding the pupillomotor fibers, because of its peculiar blood supply, the surgical lesion will cause pupil dilatation, whereas medical lesions spare the pupil. Inside the orbit, the lesion will result in either divisional palsy or isolated muscle palsy. This is our cadaveric specimen preserved in our museum, which you can visit after the class. What is the take-home message? Yeah, a thorough understanding of the anatomy and pathology can be life-saving. There will be a post-class test. I will be sharing the Google Form questionnaire link. Please let me have your feedback. Thank you.
Over to the students. Yes.
Good morning, madam. So, if we have a patient with third nerve palsy and we are able to diagnose it, what should we do after that? Can you simplify localizing where the palsy has occurred?
Lesions will be at nuclear level, fascicular level, basilar level, cavernous level, or orbital level. At the nuclear level, we apply the Daroff rule. That is, obligate the nuclear lesions, obligate lesions will result in bilateral partial ptosis, bilateral third nerve palsy without ptosis, and unilateral third nerve palsy with the contralateral superior rectus involvement. It will, in case of exclude nuclear lesions, it will include internal ophthalmoplegia, unilateral internal ophthalmoplegia, bilateral complete ptosis, unilateral and unilateral external ophthalmoplegia. In case it's neither obligate or include third nerve palsy include bilateral ptosis plus bilateral third nerve palsy, bilateral medial rectus palsy, and bilateral internal ophthalmoplegia. Then at fascicular level, these various syndromes are there, and each have clinical features. You can refer and you can do that homework. Basilar part, lesion is result in isolated third cranial nerve palsy. In isolated third cranial nerve palsy, usually surgical lesion involve pupil dilatation. Medical lesion will spare the pupil. Cavernous sinus, isolated palsy is not possible. The trochlear nerve passes above and the abducens nerve passes below. So it involves the fourth nerve involvement and first division of fifth nerve involvement.
Madam, can I ask you a doubt? Madam, aberrant regeneration, what is that? I didn't understand at all.
Complete third nerve palsy traumatic lesion, there will be endoneural there will be involvement of the endoneural sheath, there will be false involvement of the false myelin tube. It will grow in wrong myelin tube and supply the other muscles. The third nerve supplies almost all the extraocular muscles except two muscles. So it can, the aberrant nerve supply, which can supply either muscles. So it will result in aberrant degeneration. It will result in lid dysgenesis, pseudo-Argyll-Robertson people, and
Thank you, madam. It is extremely difficult to teach all these good students, no?
yes, sir.
Very difficult, huh?